Okay, guys, I think we should start now. I'll just start sharing my screen. Yes. Hi, Dr. Namrata. We can see you now, but I think there are 4 people with your name. So I think, yeah, you're muted. Just unmute yourself.
Okay, probably I sent them the link, that's why.
Don't share this link because else you may be logged out.
So should I send them a newer one?
No, you send them the registration link. They'll automatically get the link.
Okay, should I do that now?
Yeah, just do that, and I think
I'm not aware who all, just a minute.
it's okay. So guys, let's start. Meanwhile, we can just get started. I hope you guys can see my screen now.
Yes, we can see.
Great. Let me check whether Dr. Ashu is also here. Okay. I think Dr. Akhil, you can guide Dr. Ashu to just join in. Okay. Meanwhile, we'll start. So welcome everyone. This is the 57th Pain Journal Club, which is the second last journal club in the cancer pain series. This is the season 2. I'm very happy to share the topic for today, which is abdominal wall and visceral pain. So I think before we go ahead, what we're going to do is we're going to have a short introduction. And as we know, pain medicine world over has got a lot of diverse issues and variable standards, different learning requirements, and different offerings. So money and time is something which prevents the pain physicians from learning the nuances of this very special branch. And to overcome this, Mumbai Pain School is formed as an initiative of Panisha Spine Wellness and Pain Relief Center with our focus on spreading online education. We're using various social platforms like Facebook, Instagram, Twitter to promote our content, which is mostly online learning. On-demand videos. We have both free and paid content, but also we have offline hands-on workshops. Our next workshop will be held in September 16th to 18th. We are very fortunate to have the expert faculties from all over the world. It is said that the best teachers, they teach from the heart and not from the book. And Journal Club is nothing, it's just a club where different people come together to critically evaluate the recent academic literature, which is based on a defined subject. Attendee participation is encouraged. So guys, please feel free to put in the questions, comments, suggestions, feedbacks, any emotions which you may have, and we'll be very happy to take them. It's extremely tough to be regular. Many of us have persisted, so you can too. So try to be regular and try to just attend these sessions, or if you miss them, we always post, or mostly we post recordings. So just go through them. Journals are extremely important. Even Harrison used to have his own journal club, which he used to conduct twice a month. It's important to be in discipline. So I request both the speakers to stick to the timelines. Healthy skepticism or praise is most welcome. So we encourage that. So this is a bit about me. I'm a pain physician practicing exclusive pain medicine in Mumbai, and this is about our faculty today. Dr. Ashu Jain. He's done his MD and FIPM. He's the head of Department of Pain Medicine and Palliative Care at Artemis Hospital, Gurugram. Probably the first head of department to in a private medical college who had a separate department all to himself. So he's experienced faculty across national and international conferences, and he's examiner also for FIAPM, which is a program run by Indian Society for Study of Pain. He's also the program director for FIAPM for his institution. So we have our second faculty today, Dr. Amitesh Pathak. He's very accomplished. He's got his DNB as well as the PDCC in pain management from the Banaras Hindu University. He is working as assistant professor and in charge of the pain clinic at Integral Medical College in Lucknow. He's also the founder of Dr. Pathak's Pain Clinic, Lucknow. His area of interest include endoscopy in pain medicine, and also he's got a number of national and international publications to his credit. Welcome, Dr. Amitesh.
Thank you, Sidharth.
Okay, so I think we can now take the presentations. So you may start sharing the screen. I'll just introduce you. Yes, so Dr. Akhil, can you put on your CV slide? Yeah. So Dr. Akhil Bhalla has done his MD and fellowship in pain medicine from the Patil University in Mumbai, and he's currently working as assistant professor and in the Department of Anesthesia and Pain Management. He's also the in charge of pain and palliative care at Adesh Medical College in Ambala. He's a founder and consultant at Akola Advanced Pain Management in Chandigarh. So welcome, Dr. Akhil. The stage is all yours now. You can proceed.
Thank you, sir. Thank you. Okay, so good evening, everybody. So the first article that we will be discussing today will be abdominal wall pain, clinical evaluation, differential diagnosis, and the treatment. So this was an article published in the American Family Physician 2018 and conducted by Brian Shan and Scott et al. And in the University of Iowa Carver College of Medicine, Iowa City, Iowa. So there were early case reports in early 1970s which suggested that nerve entrapment could also be a cause of abdominal wall pain, and the physicians were able to successfully treat such pain with local injection. So the abdominal wall pain in itself is an umbrella term, and the most common etiology being a benign nerve entrapment. The patients could be exposed to unwarranted invasive procedures such as endoscopies, laparoscopies, or cholecystectomy. And the critical task for a physician is to diagnose or to distinguish between benign etiology from far more serious intra or extra abdominal causes. So coming to a bit about the anatomy, the applied anatomy for the anterior abdominal wall. So along the midline, the rectus abdominis causes localized pain on the xiphoid process superiorly and the pubic symphysis inferiorly. The pyramidalis muscle can also cause pubic area pain as seen here. And on the lateral abdominal wall, the three layers formed by the external oblique, the internal oblique, and the transverse abdominis form the lateral abdominal wall. These three muscles, they epineurose, they form epineuroses together and form the rectus sheath, which encloses to the inguinal ligament interiorly, the linea seminolaris laterally, and to the rectus abdominis and the linea alba on the midline. So coming to the nerve supply of the abdominal wall, the abdominal wall is supplied by the anterior or the ventral rami of the T6 or T6 to the L1 spinal nerve. The branches from the T7 to the T12 ventral rami, they enter the lateral edge of the rectus abdominis at a 90-degree angle. And when they do enter, they progress anteriorly through the anterior rectus sheath. This is where they enter, and they form the anterior cutaneous nerve of the abdomen. This is the most common etiology for the chronic abdominal pain. The L1 nerve bifurcates into the iliohypogastric and the ilioinguinal nerve, and they pierce the external oblique aponeurosis and superior to the superficial inguinal vein, whereas the ilioinguinal nerve passes through the inguinal canal to emerge through the superficial inguinal vein. So coming to the differential diagnosis which can be there, the most common cause of the abdominal wall pain could be anterior cutaneous nerve entrapment syndrome, or also known as acne. And at the lateral border of the rectus muscle, it occurs. Intra and extra abdominal pressure or any scar formation which may be caused due to this causes traction on the nerve, leading to irritation of the nerve and potentially causing nerve ischemia. Similarly, ilioinguinal and iliohypogastric nerve entrapment is also quite common, especially in patients with a history of lower abdominal pain surgery, lower abdominal surgeries, particularly herniorrhaphies, appendectomy, and procedures which incorporate a Pennenstein incision. Diabetic neuropathy, thoracic spine radiculopathy, and post-herpetic neuralgia are quite common causes of abdominal wall pain, but they need to be ruled out. Sports hernia are again a common cause of groin pain in many athletes. Incisional hernias can occur wherever there is an incision in a previous post-surgical patient. Non-incisional hernias tend to be localized to the epigastric areas and the umbilical area in the midline or laterally in the groin or around the linea semilunaris. So these are some of the many differential diagnoses of the abdominal wall pain. It will be covered later, and it will be discussed as an algorithm later, which was discussed by the authors. So this is important, how to differentiate clinically between abdominal wall pain from intra-abdominal visceral pain. So on the imaging findings for a visceral pain, often you'll find many imaging positive, whereas in wall pain, it will be mostly unremarkable. The Carnet's test, which is to be explained later, is always positive in an abdominal wall pain patient, and highly less sensitive for a negative result in an abdominal wall patient. Constitutional symptoms are definitely present for visceral pain, absent in abdominal wall pain. GI symptoms are absent in abdominal wall pain. Laboratory findings are usually within normal limits in such patients. Pain characteristics are unrelated to the meal or bowel function, and constant or maybe constant or fluctuating, and may be associated with movement and non-peristaltic. And females tend to be preponderant for abdominal wall pain, and a clearly identifiable superficial tender area of less than 2 centimeters delineated by a fingertip is a typical tender spot as seen in the chronic abdominal wall pain patient, typically near the rectus abdominis. So coming to evaluation in such patients, the pain in the abdominal wall is typically provoked by a physical movement such as lifting, bending, laughing, straining, and twisting. This is how a patient usually presents. Precipitating and associated factors are very crucial for the diagnosis in such patients. So to rule out an intra-abdominal etiology, you should question the gastrointestinal, genitourinary, and the constitutional symptoms. History should include any previous surgery, injury, trauma, diabetes mellitus, or a back problem to rule out any neuropathic causes for such pain. And the patient's ability to localize the pain with a fingertip is highly suggestive and very sensitive for abdominal wall pain diagnosis. The patients with such pain often have comorbid obesity, and the validated screening tools can also be helpful. There was a 18-item patient questionnaire, a lengthy systematic questionnaire, which was provided with this article. You can go through it. So the examination for a Carnet test is very crucial in the evaluation of the abdominal wall pain. In supine position, identify the point of maximal tenderness on the abdomen, and constant pressure is applied to the spot. The patient is asked to cross his arms over the chest, lift the head or shoulders from the examination table. This all is basically done to tense the abdominal muscle. An alternative to be used could be raise both the legs with the knee extended, and again you tense the abdominal vessels invariably. So a positive test elicits stable or worsened pain, indicating a abdominal wall etiology. In a negative test, in which some cases even the pain improves, this suggests that the pain could be likely of an intra-abdominal or a visceral origin, and it can highly be challenging in patients having a psychogenic abdominal pain. A modified Carnet test was previously also used and described for pelvic pain, and again tenderness during bimanual pelvic examination was seen, and if positive, was positive in the external abdominal palpation, elicits pain in such patients. So this is an image taken from the internet, and this is typically how a Carnet sign is seen. You palpate to the maximum point of tenderness on the abdomen and ask the patient to either lift the chin and the shoulders from the table, and the patient will have a severe increase in pain. And alternatively, you can ask the patient to lift the legs, and again the patient will have increase in pain. This will be present in cases of chronic abdominal wall pain. If there is no increase in pain and in fact even relief in pain, then the source could highly be visible. So coming to diagnostic imaging, and ultrasound, or as we know it as focus or point of care ultrasonography, is very helpful in evaluating abdominal wall pain. It can be used to detect masses, abscesses, hematomas, edemas, and slipping rib syndrome. It offers a dynamic evaluation for the hernia and provides a guidance for therapeutic or even a diagnostic trigger point injection. CT and MRI, many advanced imaging modalities, are generally not required unless there is a diagnostic ambiguity or concern about an intra-abdominal etiology, which could be ruled out later. Diagnostic trigger point injections with or without guidance, preferably with ultrasound guidance, can help confirm the diagnosis of a nerve entrapment. The USG provides better needle visualization and avoiding any accidental entry into the abdominal cavity. In trigger point injections, the author suggested 5 to 10 ml of 1 to 2% lidocaine injected deep into the fascia and muscle at the point of maximum tenderness in the abdomen. And a pain improvement of more than 50% confirms the diagnosis of abdominal wall pain. So this was the algorithm for the evaluation of a patient with abdominal wall pain. And it starts with a positive Carnet's test, which has already been explained. And if the test is positive, then you would still find for clinical findings which suggest any intra-abdominal visceral disease. So all those constitutional symptoms or GI symptoms or any other colicky type of pain, then you would again re-evaluate the patient for intra-abdominal visceral disease. If all of this is not present and the patient had a positive Carnet's test, then you would rule out a T7 to T12 tenderness or an ipsilateral spinal pain. If that is present, it could be a radicular source or a spinal source. If not, then you go for detection on an ultrasound for a mass or a bulging, which is detected on an ultrasound. If present, then you would try to rule out diagnosis such as abdominal wall endometriosis. If there is a mass which is associated with the decreasing hemoglobin level, it could be a rectus sheath hematoma. If with cyclic pain and a mass which is bulging with variable sizes, it could be hernia. And if still not, then there could be other painful masses or lesion which could be present even subcutaneously. Coming to the bulging mass detected on an ultrasound, if there is no such bulging mass, then you would look for a trigger point at the groin incision. It could be most likely an ilioinguinal nerve entrapment. If not, then a lateral rectus muscle pain. If yes, then it could be an anterior cutaneous nerve entrapment, which is the most common one. Pain at the pubic area could be because of a sports hernia or myofascial pain. At the costal margin could be because of a slipping rib syndrome or chondritis even. And at the xiphoid process could be because of xiphodynia. And if still there is no diagnosis and you cannot rule out, then it could be termed as idiopathic. So coming to the treatment. So the most commonly prescribed medications for an abdominal wall pain patient would be antispasmodics, muscle relaxants, and oral anesthetic. The effectiveness of such drugs in this diagnosis is not consistent, and it is also not evidence-based. The same is true for many other things which are followed, such as icing, massage, or even topical anesthetic. A relatively high failure rate of a simple local anesthetic injection. To avoid it, a combination of local anesthetic along with other agents such as corticosteroids and even Botox and phenol are sometimes used. An alternative to the local injection in the trigger point could be a tap block, a rectus sheath plane block, a chemical neurolysis with phenol, or a radiofrequency denervation. Again, when all of this fails and there is no intervention left to be done, then a surgical neurectomy could be done in which a portion of the entrapped nerve is removed, and it can be considered in cases of acnes which require more than 2 injections and still having not more than 50% relief. And so the authors also suggested a stepwise management approach, starting from the use of pharmacotherapy, following up with minimally invasive interventions, followed by surgical neurectomy is recommended. So this was the regimen which was given for a trigger point injection. This was an update from the previous paper which was published, and the regimens showed that even with a single injection, 78% improvement was the maximally seen with methylprednisolone 40 mg when given with 1.5 to around 2 ml of 2% lidocaine. And this increased to 99% with more than 2 injections. So overall, the maximum benefit was seen with use of methylpred with lidocaine 2%. Then again, a single injection 68% relief was seen with betamethasone 4 mg, along with 2 ml of bupivacaine 0.5% and 3 ml of lidocaine 2%, which again increased to around 95% overall with more than 2 injections. There was limited data supporting lesser dosages of bupivacaine and lidocaine along with 3 mg of betamethasone, and again 89% overall relief with triamcinolone. So the maximum relief was with methylpred and lidocaine. So again, the authors also suggested an algorithm for the management of acnes, which is the anterior cutaneous nerve entrapment syndrome. So again, when the Cartnet test was positive, which suggested acnes, a local trigger point injection was done with an anesthetic, preferably with a ultrasound, and it was confirmed as a diagnosis when the pain relief was more than 50%. If the pain relief was not long term, which was described as less than 3 to 6 months, then you repeat the local trigger point injection with anesthetic, and now you add a corticosteroid to it. And still, if there was no long-term pain relief, you would go for a multimodal approach. So the multimodal approach was seen as 3 approaches which could be followed. One, that you could repeat the trigger point injection, but this time with other agents such as phenol, alcohol, or Futox. You could even consider other ultrasound-guided blocks on the same affected side. That could be a transverse abdominis plane block, a rectus sheath block, with or without corticosteroids to look for any pain relief. And you could even consider radiofrequency ablation or neuromodulatory techniques as the patient had relief, but not long term with your previous interventions. Again, if the patient, in spite of all of these, still had no long term pain relief, the patient should be referred for anterior surgical nerectomy. And again, if there is still no relief, then a repeat nerectomy could be performed. Coming to the critical analysis. So this article was an update to the previous article, which was termed as the abdominal wall, an overlooked source of pain, again by Suleiman et al. And with this time, they had updated the dosages of the medication used in the intervention. The authors searched the data for only a brief period of 1.5 years, that is from 2017 to 18, and formulated a consolidated informational article based on other researches in the abdominal wall pain. And the sources for this article were highly heterogeneous, but sufficient enough for an informative article which could give an algorithm, but it should not be confused as guidelines for the abdominal wall pain and the interventions which are to be performed. Then again, the algorithm which was given for the management of abdominal wall pain with the use of these interventions need to be further evaluated for their efficacy and any long-term benefit to rule out any other diagnoses which are seen. So the take-home message is that abdominal wall pain itself is a gravely overlooked, grossly misunderstood, and almost always misdiagnosed. The algorithm provides a detailed multimodal approach for diagnostic intervention, and if they are successful, could be followed by a radiofrequency ablation or neuromodulation, providing long-term pain relief. And if still there is no relief, they could go for a nerectomy or a surgical nerectomy. Thank you.
Great. Thank you, Dr. Akhil. I think we should move to the second paper and then we'll take the questions together. What do you say, Dr. Amitesh? Will that be fine?
Yeah, that's perfectly fine. We should go with the second lecture.
Great. So, Dr. Namrata, you can start sharing your screen and please put on your CV slide. I will introduce you. So Dr. Namrata Bhagwat is MD in Anesthesiology, Fellowship in Pain, Diploma in Nutrition and Fitness. She's a consultant pain physician at the Vatsal Pain Clinic, Vatsal Hospital, Akola, Sant Tukaram Hospital, also in Akola, and she's also a fitness and nutrition coach with Fitter. So over to you, Dr. Namrata. Thank you.
Good evening. So the article which I am going to talk about is splanchnic nerve neurolysis via the transdiscal approach under fluoroscopic guidance. So this is a retrospective observational study. It was published on the April 1st, 2022 in the Korean Journal of Pain by Zhenhua Kai et al. At the 4th Affiliated Hospital of Harbin Medical University, China. The introduction. This seemed a novel technique of an important block, which is a splanchnic neurolysis. And as it is, there are people doing it paravertebrally under fluoroscopic guidance and in CT scan as transdiscal approach. So the authors tried to minimize the radiation with optimum route. So they did the retrospective study to find out how to minimize the radiation and avoid injury to paraspinal organs. So under the conventional fluoroscopic view. Introduction is that most patients of upper abdominal cancers, pancreatic cancers, gastric cancer, and liver cancer have severe abdominal pain in middle and the terminal stages. Most cancer patients can be treated with drugs, but approximately 20% of patients do not achieve satisfactory analgesia with higher dose of opioids or have a poor quality of life due to serious side effects such as nausea, constipation, and urinary retention. The neurolytic celiac plexus block and the splanchnic nerve neurolysis work by blocking the signal transduction of visceral pain. The neuraxial celiac plexus block has been performed with different techniques and various guidances, including percutaneous, retroflural, transaortic, and gastric endoscopic approaches. So, neurolytic celiac plexus block and splanchnic neurolysis. Now, a satisfactory therapeutic effect in the celiac plexus block is determined by an ideal drug distribution, but this may be distorted by enlarged tumors or lymph nodes satisfactory distribution of the neurolytic agent. This is the celiac plexus. So it might be distorted, and then the drug spread will not be ideal. So the splanchnic nerve is the main origin of the celiac plexus. It arises retrocrurally. It carries nociceptor afferent fibers of the upper abdominal parenchymatous organs. It is situated posterior to the crura, piercing it at T11-12 level to join the celiac ganglion to form celiac plexus. The retrocrural space is a potential triangular space. So the effect of the neurolysis, splanchnic neurolysis, is rarely affected by the surrounding structures. Several trials indicated that splanchnic nerve neurolysis is better than celiac plexus block. There is less opioid consumption, fewer complications, and a better quality of life compared with celiac plexus block. Primary puncture method for splanchnic nerve neurolysis is retrocrural or paravertebral approach guided by fluoroscopy or a transdiscal by under CT. Paravertebral pathway guided by fluoroscopy, there is a risk of pneumothorax and vascular injury. The CT guided exposes patient to higher dose of radiation. Hence, the authors aim to perform the splanchnic nerve neurolysis via transdiscal approach under fluoroscopic guidance and observe the feasibility of this technique for treating epigastric pain. Methods. The participants were patients with upper abdominal cancer pain who underwent the splanchnic nerve block via T11-12 transdiscal approach under fluoroscopic guidance. Inclusion criteria were these, that is diagnosis of abdominal pain and referred back pain, secondary to cancer. Severe pain, score greater than 7 even after pharmacotherapy, intolerable side effects from opioid, or a desire for further treatment, or more than 50% relief in pain intensity with a diagnostic splanchnic nerve block. The exclusion criteria were like any other invasive intervention like coagulation, dysfunction, local or systemic infection, hypertension, poor cardiac reserve, refusal to participate. The procedure, each patient had fasted for 6 hours and was water deprived for 2 hours, and the narcotics were stopped on the procedure day. The patient was placed in a prone position with a pillow under the upper abdomen, and the peripheral IV line was established. The patient was given inhaled oxygen at 3 liters per minute with a nasal cannula and received a rapid infusion of 500 ml of 0.9% saline. Vital signs were monitored, including ECG, BP, and oxygen saturation. Pre of 0.02 mg per kg of midas was intravenously injected for sedation. The vertebral bodies of T11 and T12, this is T11, 12, were identified in the AP view, and the image intensifier was adjusted to keep the inferior and superior end plates of T11-12 placed in a line. The fluoroscopy tube was then rotated to an oblique ipsilateral position, making the tip of the superior articular process of T12 point to the midpoint of the T11 vertebral body. The puncture point was intersection of this line and the middle point of the lateral margin of the superior articular process of the T12 and the initial line. So this was the point of puncture. Before the puncture, the needle 22 gauge 150 millimeter was curved approximately 10 degrees at the first proximal centimeter from the needle tip. Using coaxial technology, after reaching the first landing point, that is the SAP, the needle tip was slipped over the upper joint and entered into the disc. When the tip of the needle approached the front edge of the vertebral body, the stylet was pulled down and a 1 ml syringe with 0.2 ml saline was connected. Then the needle was pushed forward carefully and stopped immediately when injection resistance in the syringe disappeared. The fluoroscopy was then adjusted to confirm whether the needle tip was in the correct position. The final ideal position of the needle tip would be at the middle of the disc in the AP view and at the front edge of the vertebral body in the lateral view. After the needle tip reached the correct position, a 5 ml mixture of contrast agent and a local anesthetic, which contained contrast 2.5 ml and a mixture of lignocaine bupivacaine 2.5 ml. This was injected with an increment of 1 ml. The ideal spread would be seen as a honeycomb covering the bilateral vertebral body in the AP view and confined to the prevertebral tissue plane covering the T11-12 vertebral body in the lateral view. If the contrast agent was distributed on a single side, the needle was withdrawn and used to perform a second puncture to supplement the distribution of the agent till the drug distribution was satisfactory. In rare cases, a second needle from the ipsilateral or contralateral side was used to supplement the distribution of the agent. The patient was returned to the ward if the vital signs were stable and no complaints of discomfort were made after 10 minutes of observation. The patient was ordered to maintain the prone position for 2 hours and then moved to a supine position for the next 24 hours. A diagnostic block was performed the day before with a total of 5 ml 1% lignocaine and 0.5% bupivacaine. If the effect of the diagnostic block was satisfactory, the splanchnic nerve neurolysis was carried out with an identical procedure the next day. After the contrast agent was distributed satisfactorily, a 5 ml total 99.7% of alcohol was injected within 2 minutes, and then 0.5 ml of 0.9% saline was injected before the withdrawal of the needle to avoid alcohol flow in the path of the puncture. Now the degree of pain was evaluated on a scale of 0 to 10, where a score of 0 means no pain and a score of 10 would mean maximum level of intolerable pain, and the quality of life, in which score of 10 was the best and score of 0 was the worst prior to the procedure at day 1, 1 week, 1 month and 2 months post-procedure were recorded. The daily morphine equivalent was recorded during the follow-up. The incidences of side effect or complications related to the operation were recorded, including pneumothorax, back pain, hypotension, diarrhea, discitis, and neurological effects. Patient satisfaction was evaluated using the patient satisfaction scale, which recorded the improvement in symptoms like pain relief, somnolence, operation time, intestinal function, recovery of appetite, and weight gain, and was assessed by the patient with a linear analog scale, 0 to 10. This is where the daily consumption of morphine was also taken out from the scores. Results and discussions. So there were 40 patients which were assessed for eligibility, out of which 34 were actually enrolled. So there were 22 males and 12 females. Mean age was 60 years plus minus 12 years. They had pancreatic cancer and hepatobiliary cancer. Now, 3 patients had unsatisfactory effect on a diagnostic block, and so they did not further receive a neurolysis. So thus, 31 patients underwent both splanchnic diagnostic as well as a neurolytic block. Average operating time was 15 plus minus 5.2 minutes. So total say around 20 minutes. 17 patients were there. No, they had non-ideal distribution. 14 were resolved by adjustment of same needle, while the other 3 required another needle. Hence, a single needle success rate calculated came to be 95.4. These were the results on quality of life, the patient satisfaction, the pain scores decreased, the satisfaction increased, the quality of life increased, and the daily morphine consumption also reduced. 2 patients even stopped taking morphine 1 week after the splanchnic nerve neurolysis until the end of follow-up. Unfortunately, 1 patient died at 1 month and another one at 7 weeks. The quality of life and the satisfaction scores increased after the block, especially after 1 week. These were the complications which were found, but these all were transient and manageable. Now, the discussion is like this is a novel technique. Patients received less radiation as compared to CT. Patients had increased satisfaction and transient complications with quick recovery. In a distorted celiac flexure anatomy in advanced malignancies where drug spread is not adequate, thus the target of nerve damage is hard to reach. In transdistal, the agent was confined to the front edge of the 11-12 vertebral body and was not affected by abdominal tumors. Performance of celiac through transaortic retrocrural might lead to paraplegia, abdominal aortic dissection, renal injury, hematuria, or intravascular injection. Celiac flexure block may not be performed in patients with severe systemic disease. Splanchnic nerve space is being very small, confined triangular space. It is easy to perform than celiac flexure block. A study has found that it was comparable and alternative to celiac flexure block. Splanchnic nerve neurolysis can deliver local anesthetic to the paravertebral compartment medial to the pleural cavity, which is in the close proximity to the greater and lesser splanchnic nerves, therefore prolonging relief than the celiac flexure block. In a fluoroscopic paravertebral method, The solution is deposited in the anterior one-third of vertebral body. Now from here, it can easily spread to the backwards to the intervertebral foramen, leading to paresthesia and paraplegia, and even high risk of ripping the pleura and the vessels. A study proved that transdiscal CT guided with unilateral puncture resulted in bilateral drug. However, the radiation dose is high, and not every hospital has a CT scan. Hence, authors performed the splanchnic nerve neurolysis through T11-12 intervertebral disc under fluoroscopic guidance. Curved needle technique made puncture direction easier to adjust if the drug distribution was not satisfactory. Dose of nerve neurolytic varies, goal being achieving complete drug coverage while avoiding excessive dosage and serious complications. Various drug doses and concentration of alcohol have been used in various trials. Here, the authors used low dose and high concentration. Their initial 5 ml contrast spread was sufficient, so they took a 5 ml of alcohol but 99% of it. Generally, the agents which are used for chemical neurolysis are alcohol, phenol, adriamycin, and methylene blue. The authors used alcohol for the very properties that it denatures the proteins, extracts fatty acid substances, and precipitates lipoproteins and mucoproteins, damaging both Schwann cells and nerve cells. And this results in Wallerian degeneration. A study found that alcohol and phenol had no difference in complications and pain improvement. In present study, 99.7% alcohol was chosen, which is safe according to the literature and provided more effective block than other concentrations. Incidences of complications were lesser than those in previously done studies. A study found that transdiscal splanchnic nerve neurolysis was safer than the conventional retroflural and paravertebral approach because of a single needle through disc and lower volume of neurolytic agent. Transdiscal was also a safer route for avoiding traumatic injuries to the arteries branching to the artery of Adamkiewicz. The summary is that the main advantage of transdiscal splanchnic nerve neurolysis is it avoids the alcohol flow back into the intervertebral foramen, which might result in paraplegia and nerve root neurolysis. Avoids injury to lumbar arteries and other nearby organs. The puncture needle is relatively fixed and operation is easy and effective and safe. The main concern here is discitis, but recent studies have proven that risk of discitis is very low and could be further lowered by prophylactic antibiotics. No discitis has been found previously during splanchnic nerve neurolysis and superior hypogastric plexus block, which is also done transdiscal through intervertebral discal approach. Measures to be taken to keep the probability low are decrease the puncture times, improve operation skill, and give prophylactic antibiotics. The limitations accepted were that although the punctures were 100% successful, they still required a second needle at early stage of procedure when drug distribution was not ideal. The trial had no prospective design and sample size is small. Different effects among different types of cancers were also not observed. There was no comparative study between a traditional celiac plexus block and a splanchnic nerve neurolysis, and the effects of different drugs and different doses of alcohol were not observed. Although there were fewer complications in this puncture approach, the USG-assisted puncture might be safer, including avoiding injury to pleura and vascular injury. The critical analysis is that it's a low sample size, reporting no opioid withdrawal due to decreased morphine doses to assist analgesia. So if doses are less, then opioid withdrawal won't happen. Site through which the needle was inserted is not really clear. It depends on how you turn your fluoroscope to bring the SAP in the middle of the vertebra above. So targeted center spread basically. No comment on whether prophylactic antibiotics were given. So the take-home message is the splanchnic nerve neurolysis performed through transdiscal approach under fluoroscopic guidance is a safe and easy operation that has many advantages, including accurate positioning, being a more targeted operation, and producing minimal complications. This method could be popularized to treat abdominal cancer. Thank you.
Thank you, Dr. Namrata, for the excellent coverage of this topic as well. So now the house is open for discussion, and I request Dr. Amitesh to take forward the discussions.
Thank you, Sidharth. Excellent presentation, Dr. Namrata and Dr. Akhil Bhalla. Both of you chose a very unique presentation like abdominal pain, abdominal wall pain. It's as Dr. Bhalla has nicely mentioned, it's a very underdiagnosed thing, which we commonly don't diagnose because we don't know exactly how to diagnose it. So the chart which Dr. Bhalla showed, the Cornet sign and the algorithm, that was quite, I found it quite interesting. to diagnose exactly what the abdominal wall pain is and how we can diagnose that. So I will come to Dr. Namrata first, and I would like to ask whether I had been doing this celiac plexus rhizolysis with transdiscal approach, but have never done this splanchnic with a transdiscal approach. So I found it really interesting because I had been doing radio frequency of the splanchnic nerves. So that was interesting. I found it very interesting. And I would definitely look over it, whether I should do it or not. So have you seen any comparison between the radio frequency of the splanchnic nerve and versus this transdiscal approach in other studies?
No, it's actually quite a new one. So why I took this topic was why we selected this topic was because I also have been doing transdiscal celiac plexus when I used to do the celiac plexus. Then now I have switched to splanchnic, so I don't. I mean, I rarely do celiac plexus anymore. But this was the first paper where I found in the transdiscal splanchnic. And there's a little bit of discussion going on where Dr. Taruna is asking about needle to needle, which is a very good way to decrease the chances of infection, because then you don't carry the tag of the skin and you reduce the chances of carrying the infection or bacteria to the disc, and which is the most common cause of the disc infection. So I think there is no such a paper, but I'm sure first we should explore more about this. Is a retrospective study, so maybe a couple of our colleagues, maybe you or somebody who's watching, maybe they get inspired and then they start doing this because it is quite reliable. I still remember that it was very difficult for me to convince people that transdiscal celiac plexus is quite safe. We never had any discitis ever. Did you have any discitis in your practice, Dr. Amitesh? No. So we never had any discitis ever, and we always used to take precautions. And same way, this can be more predictable, especially in cases, wherein you can more reliably and it's quite fast, and it's quite reliable, and the kind of give you get as soon as you enter the space, there's no doubt about it. And not to mention the precise location where you reach, and it is quite easy to reach the center. And also you can considerably manipulate with the help of your bent tip. You can manipulate a lot in even inside when you are going through the disc. So it's quite steerable, and it's quite precise location which you can achieve. So I think it will be great to see such more, but right now there's no comparison.
Yeah, right now there is no count. Earlier, for advanced CI, I mean CA gallbladder and all, in which there is more involvement of advanced malignancy with the involvement of the celiac, enlarged celiac lymph nodes. What I used to do is doing a splanchnic RF along with a celiac alcohol rhizolysis. So now a new thing you come up with, Dr. Namrata. So definitely we are going to try this one. And some of you, definitely we can do some studies, or we can start with few cases, then definitely we can go on a study for that.
Great. There are some discussions. There's one comment by Dr. Taruna. She says hypogastric block she's done with, she had accidental disc puncture, but she never went transdiscal. So Dr. Taruna, I have done hypogastric also transdiscal, and it is, believe me, it's much more. You get exactly bang in the center, and you get with one needle, you get a good dye spread with excellent result. But of course, if you want to avoid that, that's your call, and you can go almost just besides and hugging the disc body, and still you should be able to get a good spread. Of course, that's also possible. So anything else, Dr. Amitesh, would you like to ask or
My
add?
experience with superior hypogastric, I have mostly have done it transdiscal only. I've never found any discitis per se, and I found it very effective, the superior hypogastric. But I never thought of splanchnic doing a transdiscal, so that's quite interesting.
Yeah. So for those of you who don't know, we have done our fellowship together, me and Dr. Amitesh. So probably a part of our practice is almost same. So that's why he's also fascinated by what I was fascinated with. So as soon as I saw this paper, I just found that okay, at this we have to read this by heart. So Dr. Taruna is asking, are you giving antibiotics routinely? Yes. So we do give antibiotics routinely, but not in the disc. So we never gave anything while we were traversing in the disc. But yes, IV. Yes. Dr. Amitesh, did you give any antibiotics in the disc while you were passing through it ever?
Definitely no, never.
Never.
It's always good not to put anything inside the desk. Or if you have IV access, why not give it an IV antibiotic?
Yeah, so there are disc is an avascular space, and still there are so you can use the same ones which you would normally use probably in uh, suspected discitis or something. So cefazolin is one very recommended one, and in fact in some of the cases wherein you have given a good prophylaxis, you also have a peace of mind. So I usually give once before the procedure, and also once after the procedure if the patient is staying overnight in the hospital. I usually keep such patients at least for 12 hours, although I can easily discharge them after say 2-3 hours or 6 hours maybe. But I tend to keep them for a longer period for just getting that one IV shot. And also in sometimes that might be an insurance mandate as well. So that's our practice. Okay, anything which Dr. Namrata or Dr. Akhil, you both will like to ask or comment? Any audience questions?
Sir, I would, sir, in the paper also, and Dr. Namrata's paper, it was discussed that during neurolysis, the patient was subjected to block first, and then the next day alcohol was given. So I don't think we usually do that in practice. We would rather post the patient
Ideally
for
the
one
same.
procedure only, and
Yes.
give alcohol, give local injection, and then wait for having a good relief for around 5 to 10 minutes. If the patient does not have any relief, then you would still consider going further with the procedure or not. But before giving alcohol, you can definitely wait for 5 to 10 minutes and having any.
Yes,
So
I
We
totally
decide
understand.
that and on the table itself.
yeah,
Yes.
but my purpose of giving alcohol has this local has never been to confirm the spread and all that. I would always give it to reduce uh,
Same.
the pain
Yeah.
caused by
Stinging alcohol.
yes, because the reason is that more often than not it's very difficult for patient to tell on the table whether they have relief or off, unless they are in acute pain and the relief is absolute.
Dramatic.
Yeah, so that might be challenging, because if the patient is in acute pain, now the challenge is how you will make them lie prone for long.
Prone.
Yeah, so because in India or in my where I practice, the patients are inevitably coming quite late. They are at advanced stage of their cancer, and they have referred to for palliative care, and then they understand that, oh, this was something was there. And then those of ones who are googling or were searching, they in fact themselves they ask, and sometimes we have now created awareness with our oncologists and also palliative care guys, and they start referring us. So it's very difficult for us to um, mix those things. So it's very difficult. So first thing, when patient comes to me with abdominal pain, so I'll ask them before the procedure, can you lie prone? So then we talk. So of course, other than the medical management, but if they have to have a procedure, I would like them to lie prone for at least some time. Maybe I will ask for say 30 minutes or something like that.
Yeah, there's one question related to this one. In a recent 7 days back, I had a patient 90 years old having a CA pancreas, and I planned for this celiac along with splanchnic, but the patient inside the OT, the patient couldn't lie prone. So I tried to give midazolam a bit, but 90 years old, I didn't want to take a risk, so I had to abandon the case. if this kind
There
of
is a very easy solution for that. So I learned it when I went for a program at AIMS with Dr. Sushma Bhatnagar and Dr. Rakesh. So what they were doing that time, I think they were the pioneers who kind of really popularized the technique. They were just making the patient was lying supine, and they'll just use the ultrasound, and they go by the anterior approach. And they did it in such numbers that it was, because I used to think, oh, what will happen, where we are going through liver and we go to every place. So it's quite simple. And if I were allowed to carry an ultrasound, because of the PNDT, I cannot. But if I were allowed to carry that mobile ultrasound, I would easily, take up home palliative care for just this one procedure, because it's just so convenient. And you could have what the next time you get this, you do this for your patient. And
Sometimes the probe we have to press to see the Siegel sign. So sometimes even that causes pain, but sedation in supine is still easier than sedation in prone.
yeah,
Uh,
actually,
so
the patient is usually lying supine, so they will not mind, and it's the only pain is
the probe
what
pushing
you
in to
press.
find.
But let me tell you, even if you lightly hold it and try to do it, it can be possible. And the problem with this lying prone is psychological also. Patient will not be okay with lying prone. It gives them a sinking feeling. Just imagine, you are having all those symptoms of the terminal cancer patient, and then one of them is, they already have that nauseating feeling and feeling of sleep,
Unable to breathe.
psychological issues. And it's quite challenging. But I'm sure with some making some good rapport and all those things, it can be done. But if it's not done, or maybe if you are in just if you are going to do alcohol, do anterior. It's quite easy. I will in If I were to start my practice now for newbies who are learning, and if I were to put alcohol, I would not go from behind. I will just do an anterior transdiscal, anterior, ultrasound guided. I'll be done with it within 10 minutes or so. It's much quicker as well.
One thing I wanted to comment about this article which I read. So it's so appealing because mostly I do celiac plexus trans aortic. So most of these patients have deranged coagulation functions towards the end. So that time it poses a risk or a problem, or we think twice what to do. So this transdiscal splanchnic is a very appealing thing, like what they said, a closed space, not really affects a lot of arteries, because paravertebral transdiscal paravertebral splanchnic has to be done bilateral. Sometimes it poses difficulties, but this looked like an easier one, so I'm definitely going to do this.
Yeah, because I think you can approach with one needle, so it becomes quicker.
And proceed.
Plus, there is a less risk of you going through the pleura, because you have only one needle, so you half the risk. And also it appears to be much more targeted. So
SAP is much more easily visible than the ribs and the head of the ribs. And like in my practice personally, I find a lot of problem with the ribs and the vertebral body.
No ambiguity, especially if you are doing it with the bad C-arm, kind of infra which we sometimes get. And many times patient can't travel, so maybe you need to go to that hospital where they are admitted.
Yeah.
And that kind of, you're specially called, and then you find that, oh, now there's nothing is visible. So that
Even what to tell the person holding the C-arm, so he's also new. So at least we can say just make it oblique, and we can still understand like SAP midline of the upper body, then the ribs and the angle of everything. So logistically also this looks good.
So within the limits of safety, and with the interest of trying to avoid infection, I think this is a good procedure to be explored. And I'm looking forward to more work on this in the future. Great, guys. So I think Dr. Akhil or anybody wants to add, and Dr. Amitesh, we don't have any unanswered questions.
Madam has suggested one like citrazole powder mixed with contrast. I'm not sure if it is necessary for conscious care.
Pardon?
Taruna ma'am has suggested one. She has a suggestion that citrazole powder mixed with contrast. I can see in the chat actually.
Yeah. So the thing is, cefazolin, I told you already, this is one which is mentioned 2 gram of cefazolin. And this is what is, recommended if you read the literature also. I had when we were doing our fellowship, we had 2 discitis cases to manage. So I think we read discitis threadbare. And I think I was quite unfortunate to have my first discitis after 8 years of practice this year. So I am very fresh with the discitis knowledge. So I think it's a very good idea to give cefazolin. And only thing is, try not to give too much of volume, and try not to use the diluents which are considered unsafe or maybe contaminated, because so you have to be extra careful. So what she's mentioning is about the discitis, the uh, discograms, not the celiac plexus ones. And also discograms are, it's also a matter of life expectancy. You would be doing this in a cancer patient who will be having a limited life expectancy. And on the other hand, discogram is usually done in a patient who is going to have a very active life for most part of it. So that heightens the risk also. And I'm not saying that you should not be careful in these patients who are terminal, but definitely it's I would think 10 times before taking any such risk in discograms. And let me tell you, the only discitis which I had in my entire career is in a discogram and not in endoscopy. So that also speaks volume. So I have tried to improve my practice since, and being extremely diligent with the protocols. I think that's the key.
Yeah, regarding discitis, I would, me and Siddharth we both have seen discitis in VSU. And once you will see a patient with discitis, you won't forget for throughout your life. That's for sure. So if you have an experience with a discitis patient, you will be doubly sure whatever you will put in the disc. So I don't feel anyone should have an experience of a discitis patient,
It's better not to have.
not to have.
In fact, I told my wife that after, I've completed my 100 endoscopies. So now soon, someday it will be, because the percent is 2%. So it soon is that is going to happen. And, I was very taken aback, but once I came home and I discussed casually that, oh, I'll be a little, because it has an effect on your mind as well, because you feel somewhere some responsibility lies on you, and you feel again and again, you enter that cycle. And being anesthesiologist, we are always more, maybe a zillion times more careful, and we are used to 100% results. So I think that weighs a lot on your head. So great, guys. Thank you for the excellent discussion. Thank you, Dr. Akhil and Dr. Amita, for the excellent presentations. Thank you all the colleagues who have interacted, especially Dr. Taruna. We get a lot of good insights from across the continents. Thank you for joining in, ma'am. And thank you, Dr. Amitesh, for joining us. Dr. Ashu could not join because he was not well. I just called him up and he was kind of coughing. So it's extremely difficult. So we will surely bring him on in, one of the future journal clubs again. Because he's got tremendous experience, believe me, in splanchnics and all this. He's a master of that. So I think we'll learn from him soon, and wishing him a speedy recovery as well. So guys, just sharing my screen again. So this is the season 2, and we are almost closing and coming to the end. It has been actually a lot. It's a big journey coming to this 57th Journal Club. And here we are focusing on cancer pain and chronic abdominal pain. So in this season, we had a new time. We had group topics. We had 2 faculties, 2 papers, and we discussed paper in advance. And for the last Journal Club, we have the theme, which is chronic pelvic cancer pain. And we have Dr. Taruna and Dr. Krishna as the faculties. Extremely learned faculties, and lots to look forward to. And we have Dr. Sasmith and Dr. Maitri speaking on the 17th of June. That's the next Friday, 9:30 prime time. And of course, the next steps, the secret of getting things done is to act. So guys, join our mailing list. The link is, of course, in the chat box. And those of you who don't get the link, just mail me on mumbaipain@gmail.com. Suggestions, comments are always welcome. And guys, please book your dates for the hands-on MIPSIs, our cadaveric workshop, where we're going to teach both ultrasound and fluoro-guided MIPSIs, ideal for those who are either trying to start their practice or trying to get some hands-on, because you never know when your case comes and you should be ready. So just practice needling. And it's one of its kind cadaveric workshop, and this is the fourth edition which we will be hosting now. We've already done 3 very successful ones in the past, and looking forward. So guys, thank you all for joining in. Looking forward to seeing you all very soon. Bye-bye.
Thank you so much. Bye-bye.
Bye bye. Thank you.
Good night.